Thank you so much for the kind introduction. I appreciate all of your help from house to research, but I'm going to be speaking here today, as you mentioned, on breast imaging and artificial intelligence in medicine. So my disclosures. Okay, so before we get too far into the details of artificial intelligence, I want to take a step back and bring you with me into the dark room. I'm a breast imager and want to explain a little bit of what we do in the reading room. Usually it's a little darker than this, but we'll just go with it. And sort of give you a context to see how we use AI in medicine and in breast imaging in particular. So breast cancer is very common. There's over 200,000 cases diagnosed each year. There are over 440,000 deaths in the US alone. And the way that we try and mitigate that is by having these screening programs where women who are at average risk come every year starting at age 40 for a mammogram. And randomized clinical trials have shown that this is very successful, that it decreases breast cancer deaths by over 30%. And so a lot of what we do in the clinic is focused on early cancer detection, because if we detect things early, they're more treatable, the morbidity goes down in addition to the mortality. And we do that with mammograms. On the right here shows a mammogram. The yellow arrow is pointing to a cancer. And we also have other supplemental imaging tools too, like ultrasound over here and MRI to better characterize lesions. When we're diagnosing things, though, we want to increase our cancer detection rate, but we don't want to have too many false positives. That will lead us to call women back for extra imaging tests that they don't really need, as well as biopsies. And so that's always a struggle to try and maximize our diagnostic accuracy while minimizing unnecessary anxiety, unnecessary medical costs, and unnecessary procedures. When we do something that's suspicious, we'll do an image-guided biopsy. And if it's cancer, we also use imaging to evaluate for treatment response and also to help the surgeons with the surgical planning. And so because of that, breast imaging has kind of led the way in artificial intelligence in medicine in general and in radiology in particular because of these reasons. One, we have big data. Because of these large screening programs, lots of women are coming in for a test where the assessment is binary, right? It's either cancer or no cancer. I see people shaking their head. There is a spectrum, but really that's what we're trying to do. And so we have standardized imaging and reporting where basically there's even federal regulation that describes how we're supposed to be doing some of this stuff. And we have good outcomes data too. We know who gets cancer in the future, who doesn't. We have some follow-up. And for all of these reasons, it sort of makes it an ideal structure to develop some of these tools, because when we read about using AI in healthcare, a lot of it is based on certain diseases. There may not be enough data or enough labeled data, and here we have the benefit of having more than. So taking a step back, if you think about the diagnostic radiology in general, it started over 100 years ago with Wilhelm Röntgen and the development of X-rays. But each decade or two, there's been this amazing technological advancement that's completely upended the field. So I'm speaking to an imaging group here, so you're probably familiar with some of these, but X-ray being like a mammogram, a projection image, but then CT being more 3D advancement of that. But then with ultrasound using sound waves, they evaluate different types of tissue properties, and then MRI, that could really just be a whole lecture, really a whole course in itself, talking about all the different types of tissue properties that we can create contrast with using MRI, and then nuclear medicine as well. So every couple of years, there's this new thing that comes on the scene that completely changes how we're doing diagnostics and enabling us to diagnose diseases in earlier and better ways. But if we think of the first 100 years of radiology as being these amazing developments in imaging hardware, we're starting to see that this next 100 years is characterized by similarly amazing developments, but on the software side, as enabled by artificial intelligence. So when I think about artificial intelligence today in medicine, but in radiology and breast imaging in particular, you can think about it in two big groups. One is more efficiency-driven AI, so using AI tools to try and decrease some of the more mundane, repetitive tasks that we do. So for instance, in breast imaging, it might be looking at a screening population, reading all these mammograms, but knowing that over 99% of them are going to be completely negative, and maybe there's some way to sort the work list to get rid of those easy that we read. And in that way, efficiency-driven AI can decrease medical costs. It can improve efficiency and workflow, but it's not pushing the field forward in the same way that some of these discovery-driven tools are. And speaking to a research audience, maybe your heart lies more on the right, but it's basically taking the same kinds of images. These are both mammograms that we would use to train AI tools, but instead of trying to train it to identify a normal mammogram, which again could save time and money and radiologist fatigue. We can make mistakes too. This is really trying to push the field forward in a way of saying what patterns in the images may not be apparent to my eye, but a computer can notice these higher order patterns and pull something out of it. So examples of this in breast imaging would be trying to predict who's going to get cancer in the future based on looking at a normal mammogram today, which I can't do with my eye. Or a lot of the work that we're doing at Memorial Sloan-Kettering is images of cancer and predicting treatment response, who's going to respond to which type of chemotherapy. So I also want to just give a little bit of a background on using artificial intelligence in general. So AI, we can train a computer, an algorithm to take a medical image. So here, a mammogram with some calcifications and predict whether or not it's benign or malignant. So how do we do that? So about 20 years ago, traditional machine learning became commonly used in breast imaging, computer-aided detection, CAD it was called. And basically, you'd have radiologists who would sit with computer programmers, and the radiologist would tell the programmer, these are the imaging features that I look at when I'm looking for cancer. And the programmer would kind of encode that into an algorithm, search for that, and then in fancier versions, you can use some sort of machine learning classifier to then take those features that were extracted, sort of handcrafted features by the radiologist, and use it to determine whether something's benign or malignant. So I should say, that became very popular about 20 years ago. Medicare started reimbursing for CAD, and then it became very popular. But then larger studies showed that actually it was not improving our performance and even maybe decreasing it, and it became less common to use. But there's a new wave of AI tools by deep learning, which are more powerful. And the big difference here is that with deep learning, you have the AI model doing not just the classification at the end, but the feature extraction as well. So you don't need the radiologist to tell the programmer, these are the things I look for. You just take many, many examples. And this is an example of supervised learning where you have a lot of mammograms, some benign, some malignant. We know that and label it. And then the computer kind of on its own figures out which are the features that are important to classify something as benign or malignant. And when you have enough data, and you need a lot of data, more data than with the traditional machine learning, this performs above and beyond that and reaches the level of human performance or maybe even exceeding it. So just to give you a little bit of a sense of how things are working under the hood, you can think of these deep learning models as very complicated equations with millions of variables or weights that we're trying to solve or optimize such that for a given image input, you get the right output. And we need hundreds, thousands, hundreds of thousands, maybe millions of cases to really span the diversity of all the different types of images that the model might see so that it can learn the right answer. And over time, during this training process, the weights of the model are optimized so that for a given input, the right output comes out. Just to give you a little bit more of an intuition of how this works, you can think of the red balls on the left as pixels in a cancer-containing image. So during training, we feed these images through the network. And let's say the convolutional neural network, which is a common type of model, gets the answer wrong. So how does it learn from its mistake? There's this process called backpropagation, whereby the wrongly classified result is passed back through the model. And the it in such a way so that when the model sees the same kind of example again, it's kind of learned from its mistake. And over time, you do this hundreds of thousands of times. And this kind of gives you an intuition of what's going on under the hood with these models. And so the next time it sees a similar type of image, now it's learned from it and it gets things right. It also gives sort of a sense as to why the training data being large and generalizable and diverse is so important, because these models are going to do best on images that are most similar to the ones on which it was trained. So I like this cartoon. It says, how does an AI model learn? It says, this is your machine learning system. Yup, you pour the data into this big pile of linear algebra, then collect the answers on the other side. What if the answers are wrong? Just stir the pile until they start looking right. So the reason why this is funny is because it's kind of how it works. Right? We're trying to look to see, oh, we're starting to get the right answers. Let's search in this model space around over here until we optimize things. So when we think about developing AI systems for clinical use. These are the steps: defining a task, collecting data, annotating data, training, testing, and then finally clinical implementation. Let's just go through the steps here. One thing I want to drive home as a clinician is defining a clinically relevant task. So having doctors involved in the process, not just finding a cool model and doing things that are really cool from a science perspective, but then you bring it to the clinic and there's not really a use for it. So making sure that there's a clinical need, that it's going to improve patient care, that it's feasible for clinical translation, would radiologists or whoever your intended audience is actually use it. And then it's important to make sure that what you're trying to do is technically achievable as well. So will it be possible to curate a data set large enough to do the task at the level that you want it done? Do we have sufficient computational power? Do we have the optimal architecture? And so even though we don't have the radiologist sitting with the computer programmer anymore, directly telling them what to put into the algorithm, it's still no less important to have this bridge and interdisciplinary relationship at the beginning to make sure that the research is being pushed off in the right direction. Then the data collection, curation, annotation, probably the most important part of the process, but the most intensive and the most painful. We need to define the right cohort, make sure we're including the right people, maybe excluding certain groups as needed, and also just being aware of biases, so underrepresented subgroups. The algorithms are going to perform best on the images most like the training set. And so if you want to deploy it on a large population, then you're going to need to make sure that it's trained on a sufficiently large group as well. And then you can organize and label the data in lots of different ways. Happy to talk about it with people later, but I think maybe not get into all the examples down over here now. And then it's really important to divide things into a training set, a validation set, and a test set, and sometimes even an external, ideally an external validation set as well. So the training set is what you're using so the model learns all those different weights or variables like I was explaining. The validation set allows you to check lots of different combinations of the model architecture, other parameters, hyperparameters, so that you can choose which model is best, right? So you train up a model, see how it does on the validation set. Train a different type of model, see how it does on the validation set. Once you've done that and iterated and found your best model, only then do you use this held out set as an external test to say, well, how does this do? And then the gold standard would be to use an external validation set, not even from your institution, maybe going around the world, as we'll see in some of the examples that I show, really show that your model is going to work wherever you're using it. So just example here, so you're training, making sure that the accuracy is good, and validation accuracy is also good, and then once you have that, only then using a test set to calculate the actual clinical performance. And depending on the task, you may care more about the sensitivity, more about the specificity. It's always good to have the clinical task in mind so you know what you're trying to optimize here. Okay, so now with that brief overview, let's talk about AI with clinical imaging. And the question is, where is AI helpful along the imaging pipeline? And I'd really argue the answer is at every step along the way. We have ways to use artificial intelligence to improve, to optimize efficiency, or to do other helpful tasks. So everything from deciding which patient needs which test, within the test, what subtype of the test, how do we want to acquire the images, how should the images be reconstructed, which is another whole area where AI is really being used under the hood in lots of clinical imaging software now, meaning creating the MRI images that we read, for example. A lot of it is being accelerated with deep learning. But on the image interpretation side, removing normal cases from a work list or sorting, making sure that in the ER we're getting the cases with the brain bleed earlier on rather than later, and then cancer detection, classification, like we talk about in breast imaging, and then predicting treatment response or prognostication. I'm going to focus on these three areas, the risk assessment, removing normal cases, and cancer detection, because those are either the closest to clinical implementation or really being implemented now and sort of bring you to the forefront of where things stand at the clinic for me today. Okay, so we'll start with cancer detection. And one of the challenges of screening mammography, as I said, you have a large population of women trying to figure out who has cancer in the most efficient way possible. So we want to try and maximize it, obviously not have missed cancer, not unnecessarily recall women. there's some variability in our diagnostic accuracy. Humans are not perfect, and also there's different levels of expertise. Some people at a cancer center, we're completely focused on this. There's more regional centers where radiologists are doing all kinds of imaging. And then there's areas around the world where there's really a global shortage of breast imagers who can focus on this sort of thing. And so artificial intelligence can help address some of these issues if we had a way to deploy it to identify sort of as a first pass which of these mammograms are abnormal or not. So if I was giving this talk about a year ago, this would be my last slide on the topic, that there have been several retrospective studies for standalone AI, meaning using AI without a radiologist to identify the mammograms, and that it performs at or above the level of radiologists. There are several really top quality retrospective papers that had been done. And in the Journal of Radiology, which is our main professional journal, there was a nice meta-analysis that showed that standalone AI really was performing at of the level of just sort of your general radiologist. In these studies, though, it's always good to go down into the fine print and see the radiologists. Were they very senior? Were they just out of training? Was it some residents who were great? But there is a learning curve that happens over time. And so that's important for AI journals, AI research in breast imaging, but really for all areas of AI in society. You just have to make some of the methods. But then also the question is, if it's retrospective, how does this translate into real world performance, high risks of study bias? How will it be integrated into current workflows? But it's really exciting because over the past year, there have been several prospective trials that now have real world initial results. And these are 4 that are registered with clinicaltrials.gov. They're all sort of similar. They're using a couple different vendors, big studies, tens of thousands of patients. And they have similar study design. I'll take you through one of them. So this was published within the past year, earlier this year. So AI for breast cancer detection and screening mammography in Sweden, a prospective population-based paired reader non-inferiority study. So basically, they take women, over 50,000 women who were just part of the population-based screening in Europe, in Sweden. Europe has an advantage here because they tend to have more nationalized programs, and so it's easier to track everything. They didn't include mutation carriers, patients with a personal history of cancer, or breast implants, but they basically were looking to see the cancer diagnosis rates within 3 months of screening. They don't yet have information on the interval cancer, so the false negatives. So that's a big piece that's still missing just because it's so early. But their primary analysis here was non-inferiority. So will the AI tool be non-inferior to the current standard of care? And the current standard in Europe, actually, 2 radiologists looking at every mammogram. It's a whole different system there. So here we have 1 radiologist who reads a mammogram for a woman every year. There they do screening every 2 to 3 years, but they have radiologists look at each scan. And so it makes it a little bit easier for them to think about creative ways to incorporate AI into their workflow, because they can swap out one of the radiologists but still have a human looking at it. With us, it's a little bit more controversial. And then so they compare standard of care to 1 radiologist and the computer versus the AI itself, and then all 3 together. And what they found in terms of cancer rate, so when they had the 2 radiologists, there were 250 cancers that were detected. When they swapped it out with AI for one of them, it actually went up to 261, which was not only non-inferior, but statistically significantly superior. When they used the AI alone, the number went down a little bit, 246, but it was non-inferior in terms of their statistical analysis. And when you use all 3, you're detecting more cancers, so 269, and it was superior as well. But just to take you through what the effects are downstream. So this in terms of the abnormal interpretation rate. So let's say you have 100 patients. How many do you call back for extra pictures? So when you're having the 2 radiologists read, that's the first bar, this red bar all the way on the left. If you have AI and a radiologist, it actually goes up a little bit. So they're flagging more cases as potentially suspicious. When you're using the computer alone, it goes down. And when you're using all 3, as you'd expect, one of those 3, it's more likely that someone's going to flag something. But what's interesting is they didn't just, any abnormal interpretation did not directly lead to a patient recall. It led to they had a consensus conference and had a few radiologists together figure out, do we actually need to recall this patient? And then you see these numbers go down. So when you have the two radiologists, here's their actual recall rate of saying, okay, this woman needs to come back for additional evaluation. The consensus conference was able to bring down the recall rates for the single radiologist in AI and the two radiologists in AI basically to the same level. And when you look at the biopsy rates, the cancer detection rates, it kind of all levels off. So it's very interesting. A single reading in AI increased the cancer detection rate by 4%. It did increase abnormal interpretation rate, as we said, by 21%. But then this consensus discussions prevented the higher recall rate. And so when you think about it, for 100,000 women, you're decreasing the reads by 1/2 by doing the single radiologist and AI, increasing consensus discussions by 1,500, but that's still a significant workload reduction. And even more importantly, I would say it's kind of a qualitative shift in the type of work that radiologists are doing. So instead of reading a bunch of normal cases, it's shifting the workflow to saying, let's have these consensus conferences for more complicated gray area cases, which I think many of us would welcome in terms of how we spend our time during the day. For the AI alone, it decreased recalls by almost half with a non-inferior cancer detection rate. But this brings up a lot of ethical issues in terms of also public acceptability of not having a human involved in the process of interpreting a mammogram. I think that's going to change over time, but sort of where we are today, there's not much interest in doing that. And also just legally right now, the FDA has certain requirements that wouldn't allow us to do that. For double reading, there was increased cancer detection, but much more work in terms of the consensus reads. And then in terms of whether or not this is ready for clinical use. So we need QA protocols, quality assurance protocols, to make sure that these AI systems, while performing at a certain level now, are not decreasing over time. We also need follow-up studies to compare the interval cancer rates. So this is what we call a screen positive study. It was only sort of 3 months follow-up to see which cancers were detected. But over the next year or so, we're going to get interval cancer rate data follow-up to make sure that in the arms where it's a human plus AI, that we're not seeing more cancers that were diagnosed sort of in the interim. But this is really exciting. And at our center, we're starting to use one of these tools as an adjunct. So not as a standalone way, but just as a way to consult what we're doing. We're going to be turning it sort of on and off for the first year. So we have our control data to see how it's working in our institution, because even though there's very promising literature showing efficacy, it's always a little bit different when it's in your own home institution. So we've done some retrospective analysis showing that it kind of works as expected, but definitely not anywhere close to the level that we would not look at the images, because there's just so many cases that we detect that it misses, and then vice versa. So it'll be an interesting area as we go forward. Okay. Shift gears a little bit and talk about cancer risk prediction. So first, why do we need cancer risk prediction? So I mentioned MRI. So that can be used to further evaluate lesions for surgical planning, but also in patients at higher levels of risk. So if you have a lifetime risk right now of greater than 20%, we recommend that these women get annual MRIs in addition to mammograms. It's a more sensitive test, so it picks up cancers earlier at a smaller size. We don't recommend it for the whole population. It's more costly. It's a longer test, and it also will lead to more false positives if you use it in patients without a higher expected rate of cancer. But right now, in terms of risk prediction, it's helpful to figure out who needs the screening MRI, and also to determine need for chemo prevention. We have certain anti-hormonal therapies that we can use to decrease cancer risk. If we were able to develop a breast cancer risk prediction program or model that was of sufficient accuracy, we could also be used to create a more personalized risk-adjusted screening paradigm. For me to stand here and say that every woman at age 40 should be getting a mammogram every single year, and no one should be getting more or less except for this one high-risk group, is a little bit outdated, even though in my society of breast imaging, that's kind of our party line. But from a scientific perspective, I think as we improve our ability to prognosticate and better triage women into these different categories, hopefully we'll see some more nuance, because that would really allow us to reap the benefits of screening while minimizing some of the harms that I talked about earlier. Okay, so what are we using in clinic today? So we're using epidemiologically based statistical models. So there's a model called the Tyrer-Cuzick model. There's a Gale model. Looks like this. Basically, you input a bunch of factors, so risk factors. So there's known factors like family history. If you've had prior breast biopsies, there's certain higher risk lesions that can get put into this model to increase your general risk. Smoking and alcohol, height, weight, the density of the breast tissue on the mammogram. These are all traditional risk factors that we use to identify whether women are at high risk, as well as certain genetic mutations that we know of. The AUCs, though, from these kinds of models range from the mid-50s to the mid-60s, so it's pretty modest. The other big problem here is some patients don't know all of their clinical risk factors, like family history, and also it doesn't work as well across all racial groups. So these models were developed on white women in the Northeast, and that's where it works the best. And so there's really a need to make sure that we're doing things in a more equitable way. So there's been some really exciting work on this front. This is a picture of Regina Barzilay from MIT. Her lab has developed an AI-based image model to predict 5-year cancer risk. And this is how it works. So they take the 4 standard views of a mammogram. So women, anyone coming for screening is getting these 4 standard views. And they have an image encoder similar to that convolutional neural network model that I was showing you earlier. They have 4 different ones that each encode features from those 4 views. And there's a way to aggregate it together. If they have traditional risk factors available, that can be put into the model. Actually, they have models to draw out those risk factors from the image itself, which is kind of neat. And then they have sort of a hazard layer to enforce some internal consistency. And then the output is the predicted cancer risk between 1 and 5 years. So they have a risk for year 1, 2, 3, 4, 5. They developed this model working, so it was MIT in conjunction with MGH, on over 200,000 patients, just to give you the sense of the size of the data sets that are needed to develop robust models. They used a validation set of 25,000 patients, and then they had another 5,000 patients that they used as a test set. What's so special about this model, though, is they did not stop there. They did a multi-site international validation, where they went around the world. There are some US sites, so Novant, 14, which has a more racially diverse group, 44,000 patients. They went to Israel, 6,000 patients. From Sweden, they had 19,000. From China, 13,000. And from South America, 6,000. And what they did was calculate a C-index, which is similar to AUC, comparing it to that Tyrer-Cuzick model that we use in clinic. The Tyrer-Cuzick model has a C-index of 0.62. And as you see here, their C-indices are higher in the 70s or even low 80s. Really, though, so this is the main table from their paper. I think the appendix is a more accurate reflection of the prediction, because in the appendix, they excluded patients who were diagnosed with cancer within 6 months of that mammogram. So you can argue that the numbers up here are not only doing a risk prediction, but doing kind of a detection on the initial mammogram. It's a little bit cheating because the Tyrer-Cuzick model isn't looking at the current state. It's more of a future risk prediction. But you still see this does outperform our current Tyrer-Cuzick model, so in the high 60s, low 70s of the C-index. And so these deep learning models perform well. There's been newer results at a latest conference, which showing really across racial groups too that this does very well. Doesn't require knowledge of clinical risk factors. You can use in patients with a history of breast cancer, with genetic mutations, prior chest radiation, although it does work best on certain vendors. So MGH uses hologic mammograms, or uses hologic to image patients, and the results show that it works a little bit better in those than in the GE model. That's something to be aware of. But it really does outperform the standard of care. There's an FDA approval process underway, and it's really ready for clinical use, but again, with this ongoing QA piece, because minor changes in imaging hardware upgrades or software upgrades that can change the noise levels or other aspects of the image where a radiologist won't notice or just see right through it, but it can throw these machines off. And so we really need better systems, not better systems, but new systems in place to try and make sure we're monitoring things over time. There's interesting questions about how to integrate it into clinical practice. What happens when the AI model is not agreeing with our current risk prediction model? If you have a woman who's been told every single year she needs an MRI, and then we say, oh, no, you don't need one anymore, that can cause some problems in the clinic as well. So trying to think about how best to transition. And then we're also looking at in-house at Memorial how it works in our BRCA patients, so patients with certain genetic mutations that connote very high of cancer. Okay. Moving along, I want to talk a little bit about triaging out normal exams. So this is one of our postdocs here, Arka. He's been working on this model where we have a huge data set of breast MRIs. We have a lot of high-risk screening patients who come through Memorial. And so the idea is to develop an AI tool to triage out completely normal breast MRIs. The way it would work is you'd have an initial image where usually a radiologist is looking at it, seeing if it's suspicious or not. But maybe you could have AI take a look and identify a subset of cases that perhaps are so low suspicion that there's no need to do anything further. So we used over 16,000 MRIs in over 8,000 patients from multiple imaging centers to basically take you through this pipeline of using a UNet to segment out the maximum intensity projection image, which is basically the image that shows where things are enhancing, where there's vascular permeability, where there might be cancer. And we do a binary classification looking at whether it's extremely low suspicion or possibly basically in a 1,400 set of screening exams. We had 59 cancers, and also all of those were triaged as possibly suspicious by the model, whereas the cancer-free exams, about 11% were identified as very, very low suspicion, and we didn't miss any cancers with that thresholding. The thing is, though, if I talk to me or any of my colleagues, we're not going to not look at these images based on evidence like this. Or even you do a multi-center trial, it really takes so little to look at the image that we would say, until there's really much more robust evidence, we're not going to not look at these images. But there are other interesting ways to use it in clinic. So one of the problems with MRI is that it takes so long to acquire these exams. So the full protocol that we do on all is about there's a bunch of non-contrast part where we can interrogate different tissue properties, looking for water content, looking for diffusion of water that gives indications into hypercellularity. But really the main workhouse of what we're doing is the pre and post contrast images where we inject contrast, we're looking for leaky vessels where when tumors outgrow their blood supply, it creates this leakiness or vascular permeability. And so that's what we do when we have this abbreviated protocol, which is not really used in high-risk patients because it's so important to make sure that when we do see a lesion, we have these other sequences to help us improve specificity. So I would say that the contrast injection part is good for identifying cancers and improving sensitivity, whereas I think I have some examples here. So in about 5% of cases, these earlier sequences are very helpful for specificity. So on the subtraction image, which is the contrast enhanced portion, I might see an enhancing lesion, but then on the T2 weighted image, it's very bright, and it's probably a lymph node or some other benign process. For an example here, we also, on the subtraction image, I have a rim enhancing lesion here. That's suspicious. But then on the T1, where fat is bright, I see there's fat within the lesion. That's not cancer. That's fat necrosis. And so these other sequences allow us to reassure ourselves and not do further workup on the patients. But the idea here is that maybe we could use our tool to put it on the scanner, have the patient have those contrast sequences first, just for a few minutes. And then if our AI tool says, this looks fine, just stop, get the patient off the table, don't have them there for another 10 or 15 minutes. And so that's kind of the way we're thinking of using this tool. We've done a retrospective study with readers showing that it works and wouldn't lead to missed cancers. And so our next step now is putting it on the scanner. This would be helpful not only just in breast imaging, but really in all areas of MRI where the protocols are set by the radiologist the day before without any information about what's going on during the study. But having an ability to on the fly could be really helpful. Okay, so I think I'm running a little bit out of time. This is kind of like an extra segue, extra supplemental part. I know we have a panel discussion later, so there's different aspects of ethics in terms of the ethics of data, ethics of algorithms, and ethics of clinical practice. Happy to stop and take questions now, or however you think. 'Cause this is like another. Just keep going. Okay. All right. Fine. I'm happy to keep talking. Okay. So in terms of the ethics of data, there's lots of questions that come up of what to do today. In terms of who owns the data, right now in the US, it's owned by the imaging centers that perform the medical imaging, although patients have rights to access the reports. In the EU, it's different. The patients really do own their image. And so any research being done, you need the consent of not only the imaging facility, but the patients as well. Here, when you're doing large retrospective studies, if everything's identified, you don't need individual consent generally. But yeah. So we have an IRB, but informed consent is waived for these cases. And then just in terms of what guidelines should govern data use, data sharing, data buying and selling now, all sorts of interesting issues come up. So whether a hospital system can sell exclusive rights to a given company, can they sell the same data to multiple companies? What company then has data that they bought from University A, they develop a model, then they buy a test set from somewhere else, but maybe that came from the same initial source. And that could really contaminate things and make things look like they're going well, but perhaps your model is not working as well. And then in terms of patient privacy, kind of interesting, there was a New England Journal article showing that CT and MRI scans of the head could be basically using 3D rendering software, create facial reconstructions that matched with publicly available photos could identify people. And that's sprung out a whole new area of research where you take raw MRI data, but then deface it to try and really anonymize it. There's now work trying to go from here to there, so it's kind of like an arms race a little bit. So we'll see what happens with that. But it just the traditional way of de-identifying of just stripping the DICOM header file of name, date, date of birth may not be sufficient in this new age. And then in terms of ethics of AI algorithm developers, really the most ethical thing to do is to follow the best practices so you have the best performing model. But there's some other considerations too. There's this growing consensus definitely within the radiology community, that the AI tools that we use should be explainable as a way to build patient-provider trust. We don't want to have a black box model. I would push against it a little bit, saying, that ultimately this is going to limit the potential of AI. If we constrain it to our human understanding, it may not be able to go in the more discovery-driven way that I was discussing before. But right now, I think when we have a tool that we're using with patients, it's very helpful. And there's sort of a consensus, like I said, that we want to explain to the patient how we came up with the decision. So if we use an AI tool to diagnose X, Y, or Z, well, here on the image, this is how the computer did it. And that's kind of something that's important to us. As I had mentioned before, also making sure we're using diverse held out test sets, making sure that it's being used, that the algorithms that we develop work similarly across genders, racial groups, socioeconomic groups, age. Because there has been a growing awareness that there are performance gaps across demographic subgroups. So I'm showing a few papers published over the past year or two. So for example, here, underdiagnosis bias of AI tools in underserved patient populations. The truth is I could show you just as many papers showing that there's no difference. So for example, it's in the cancer prediction. Earlier, that's been shown actually not to have any racial predisposition, but there clearly are other areas where this is a problem. And so that's sprouted a whole new area of research of trying to mitigate some of this bias. So the best thing to do is obviously to collect more representative data at the beginning before you start. Sometimes that's very hard or impossible, especially if you have more rare diseases or just not the populations that you need. And so there are different strategies during the training process itself that help you mitigate some of these imbalances. So one is just a class balancing strategy where during training, I was talking about shifting the weights during backpropagation. You basically take any of the underserved or underrepresented categories within your training data and weight that more during the backpropagation process. So those sort of count more during training. And then there's this whole new area of adversarial training, which is actually very interesting. So let's say you're taking a model and you're trying to predict which images have cancer or not. The model is going to be extracting certain imaging features from that initial mammogram, let's say, to identify which has cancer. The idea with adversarial training is you're simultaneously training a separate network to try and use those same imaging features that were extracted by the model to predict race, to predict gender, to predict age. But you actually want to minimize that. So you want to create a model that's able to identify the cancer or not cancer, but is not able to identify, let's say, what the race is. And so then you sort of know that you're eliminating the connections between the race and the ultimate diagnosis the model rendering, try and making sure that the model's not using any unfair shortcuts. There have been these classic cases where these models do amazingly well at identifying this, that, or the other factor, and then it was realized later on, oh, you know, there's all of the cases that had this diagnosis were from hospital X, and hospital X always has this kind of image, and that's what it was using. And so that's the big fear here, to try and make sure there aren't these confounding factors that we may not be aware of. So the problem, though, is that there may be this inherent trade-off between fairness across groups and overall performance. There was an interesting article in Nature Medicine earlier this year showing this trade-off with a bunch of different models, showing that as you improve the fairness across different groups, the overall accuracy does decrease. And so basically shows us that we still have more work to do to try and push the boundaries of this and try and make sure that we can better serve all patient populations with high performance. But an interesting aspect of this is that sometimes things are more complicated than they seem. So there was an interesting article on gender imbalance in medical image data sets. So basically, they took a bunch of chest x-rays, this group, and they were trying to diagnose 12 different diseases on the chest x-ray. One of them is a pneumothorax, which means a collapse of the lung. Sometimes it can be very subtle. Just the lung collapses a little bit, and there's a sliver of lucency along the side. So they trained these algorithms to do it, but they did it in an interesting way. So the blue here, over here is when they trained it using only male patients, and the orange is only female patients. And the intermediate colors are somewhere in the middle where they have a more balanced training set. The top here is when they tested it on the male patients, and the bottom is when they tested it on the female patients. And so if you test on male patients, the models trained on male patients are going to do better than the models trained on female patients. That's what we expect. And on the bottom, for the women, the models trained on the female patients did better than the models trained on the male patients. But here's the thing they couldn't figure out. I don't know if you can see these numbers here, but all of the male test sets did better than all of the female ones. So even the model trained only on female patients did better on the male patients than on the female patients. So they couldn't figure it out initially, I assume. Although in the discussion, they make a good point, which is women have more tissue. I mean, there's breast tissue obscuring the thorax, and so it's a more difficult diagnostic problem to identify these very subtle pneumothoraces on women. And so it just goes to show that you need to take a more holistic, larger view picture of things when we're trying to assess fairness. Oh, that's interesting. Yeah, I mean, they didn't talk about that in the paper. Usually, even with gynecomastia, it's not going to be as obscured, but that's a good point. All right, so just wrapping things up. So just in terms of the ethics of implementing things in clinic, it's important to determine where, when, and how we're doing it, making sure that the stakeholders and people involved understand the uses and limitations of AI, and making sure that we're monitoring things over time. In terms of how AI should be used, there's a lot of things to figure out just in terms of the optimal radiologist-computer interface. We talked about using it as a standalone way versus sort of as a computer-aided detection. But I think one of the important things is to make sure that we keep humans in the loop. And humans in the loop could have different meanings. On the one hand, it could be a human in the loop on the interpretation of every single mammogram, or it could be on a larger, more managerial sense, making sure that we're evaluating sort of the performance over time and making sure things are going in the expected way. But making sure that AI is subject to our judgment and control is really important. And it's important that the performance doesn't decrease over time. So active monitoring for model drift or data set shift, like I talked about, different software, hardware updates, tweaking things and throwing the models off. Also, there's a growing concern about automation bias. So there's a tendency of humans to just take the machine output maybe without as much critical thinking as they might, just erroneously accepting false positives or making too quick decisions on things that the model's labeling as negative. Also a concern about avoiding over-reliance, especially in trainees or younger radiologists, making sure that we're developing skill sets that we need. So in terms of the future, I think that we're seeing now that AI is transforming the field of radiology. There are some unresolved medical, legal, ethical, privacy concerns, but really many promising clinical applications on the verge or even in use today. We need to be proactive about ethical AI, making sure we're keeping humans in the loop and allowing for ethical oversight and accountability. Hope this was interesting to the group, and I look forward to discussing things over the course of the day. Thank you.
this very stimulating presentation. We have time for a few questions. I'm going to ask people to, when they speak, to identify themselves, your institution. Yes, please. Can you take a microphone?
Okay, I'm sure there are many institutions that are developing various models that try to do this kind of predictive analysis. What mechanisms exist to sort of give an opportunity for the different models to integrate so that you put together what you do with some other hospital and so on, or you all sort of doing your own thing?
Yeah, no, that's a great question. And that's one of the challenges of the field, is trying to break down some silos between institutions. A lot of us are working on similar types of things. And some of the privacy concerns make it hard for us to share data. There are what's called federated learning models, which is a really interesting concept, that basically, instead of the data all being shared and pooled in one location, it's actually the model that hops around. So you could have the model come and we train it on our data, and then we kind of pass it to the next institution and they train it on their data. That's been done too. We work with other institutions to build some of these models with let's say a handful of institutions, but in the US, it's hard to have a nationalized effort. They've done better in Europe, like in Sweden, the model that I showed, or in the UK, where they really have nationalized databases that make it a lot easier. And so the truth is, the model that the cancer detection software that we're going to be using at Memorial was actually developed in Europe. And I think that may be a trend, just because it's so much easier to pool data there.
Thanks. There's a fabulous talk. I really like the overview you gave. Excellent job. So I'm David Ensberg from Einstein College of Medicine. I was wondering if you could talk a little bit more about the gold standard that you're using in the clinical trial. So for example, in the first clinical trial, you said that the AI led to increased detection of cancers. So how is that really determined? Is pathology ultimately your gold standard? And then also, when you talk about risk prediction, what is the event that you're trying to predict? Is it local recurrence? Is it local progression, distant metastasis?
Yeah. Okay. So great questions. Just in terms of the second question first. So for risk prediction, it's predicting new breast cancer. So these are talking the patient population here is patients who were without a history of cancer, and so it's first incidence. We are trying to develop models for recurrence. That's harder just because there's fewer cases, right? So your pool then is the patients who already have cancer, and that limits things a bit. And so I think those models are not going to be as robust anytime soon than the sort of anything you can, whether your denominator is the whole patient, the whole US population or the population of women over 40, that makes it a lot easier. In terms of gold standard, it's something that we talk about all the time. Pathology, you guys definitely have it. You are the gold standard. The prospective trial that I discussed, there's not enough follow-up yet, but when they publish their results in a year or two, it will be based on, and what we usually do is either pathology follow-up, meaning if there was a biopsy and what the results were, or we say negative image follow-up for 2 years. And so that's sort of how things go. But many times, really, we look at you guys to being the gold standard for a lot of the algorithms that we're developing.
One last question, quick.
All right, thank you. Laurie Solomon, I'm the chair of family and community medicine at New York Medical College. And my question is really more based on an outpatient perspective. So you're absolutely right that that it's really important to establish trust between the physician and we also and the patient. And my question is, how are these algorithms being used or going to be pushed out in terms of, like, when I'm giving a recommendation on, okay, is it like this cancer center is going to be using this hospital system's using this other one? How do you compare the different models? We don't even know if you're using models right now. Is there going to be any kind of data sets or comparison between the models so that we can kind of give some recommendations for our patients?
Yeah, no, that's really important. So the American College of Radiology has done some work, and it's ongoing, to try and build up some test sets that can be used to kind of level the playing field and see what works where. I think for the next few years, though, it's going to a little bit be like the Wild West, right? So I don't know what risk prediction models you're using now. Some people are using Tyrer-Cuzick, some people use the Gale model, some people use both. I know at our center, depending on history of LCIS, maybe we'll use one versus the other. So it really varies, and this is probably going to be a variant thing too. Although these models seem across the board to be better than the traditional statistical ones. And so moving towards whatever's FDA approved is probably going to, right now, nothing is in this space, but probably the first one is going to have a little bit of a leg up, and people may run with it. It's always tough, though, because you always have to take the patient in consideration too, right? So there's some patients who are very eager to have more intense screening, some not. And so maybe this will give you kind of more options to choose from to hang your hat on whatever the recommendation is. That's kind of like the reality of sometimes how things work. So
Thank you.
Yeah.
Let's give Sarah another round of applause. Thank you so much.